Hello, everyone. Good morning, good afternoon, good evening. My name is Chavi Bhandari, and on behalf of the George Institute for Global Health, I'd like to warmly welcome you all to the fourth Evidence to Policy lecture. Each year, we host this lecture to spark a conversation around bridging the no-do gap in public health policy implementation, and it is delivered by a leading global researcher. Past lecturers have included Professor Srinath Reddy, Professor Ian Jacobs, and Dr. Rajni Vaid. This year, we are delighted to have Dr. Ophira Ginsburg join us, and her talk will focus on the intersection of two very important topics in public health, women's health and cancer. In particular, she will be sharing her perspectives on the impact of evidence-based cancer prevention and control strategies for women, especially in LMIC settings. Followed by the lecture, we have a fireside chat that will be moderated by Dr. Neerja Bhatla, who I'm sure will bring out even more interesting insights for all of us here. So we have quite a few people who have joined us from around the world today. And so thank you all. And we are keen for you to participate actively in the conversation. So please feel free to add your, post your comments and questions in the Q&A box. And also please do tweet using the hashtag Evidence2Policy, which is up on the screen. Without further ado, I will now hand over to Vivek to do the formal introductions for Dr. Ginsburg and Dr. Bhatla. Over to you, Vivek. Thank you.
Thanks, Chavi. On behalf of the George Institute for Global Health, it is my pleasure to add my own welcome to that of Chavi to our annual Evidence to Policy lecture. My name is Vivek Jha. I am the Executive Director of the George Institute for Global Health in India. And this is a very important event for us. We are so glad that you have been able to join in. Let me start by just saying a few words about the Institute. We are a global medical research institution with a mission to find scalable, sustainable, and affordable solutions to the most important healthcare challenges that leads to millions of years of lives lost and productivity around the world. And these loss of years are increasingly due to non-communicable diseases and injury. In particular, we are committed to generate evidence using collaborative research that would mitigate the widespread global inequities in access to sustainable care. And this is so critical to achieving the United Nations Sustainable Development Goals, to which all the member states have signed up. The George Institute research is multidisciplinary and extends beyond the traditional boundaries of healthcare to include all stakeholders, be they be policymakers, administrators, social scientists, economists, engineers, data scientists, lawyers, and of course, civil society representatives, including patients themselves. Women's health is an important and rapidly growing program across all offices of the George Institute in Australia, UK, China, and India, and we are building links with partners to develop a context-specific program of research in India. As Chavi pointed out, Dr. Ophira Ginsburg joins a relatively short but distinguished list of academics, researchers, and policy specialists who have delivered our Evidence to Policy lecture. Professor Ginsburg is the director of the High-Risk Cancer Genetics Program at the Department of Population Health at New York University Grossman School of Medicine. Dr. Ginsburg is a medical oncologist, which means a cancer specialist, based at NYU Langone's Department of Population Health, and she's an expert in cancer epidemiology, prevention, and screening. She investigates causes of cancer and cancer disparities within global health, and is keenly interested in promoting equity in women's health and global cancer control. She holds academic appointments at the University of Toronto, the James P. Grant School of Public Health at BRAC University, Bangladesh, and at the Institute of Cancer Policy at King's Health Partners, London. She juggles both a clinical and research career. For the last 15 plus years, she has been studying cancer disparities in North America and in low middle income countries with the goal of improving outcomes, particularly for women. Her program of population intervention research, training, education, and policy initiatives in global cancer control has projects in many countries, including Bangladesh, India, Tanzania, and Vietnam, besides US and Canada. She has been an advisor to the National Institute for Cancer Control in Vietnam, a member of the Technical Advisory Committee of the Global Task Force on Expanded Access to Cancer Care and Control in Developing Countries, and a member of the Union for International Cancer Control's Global Task Force on Radiotherapy for Cancer Control. In a past life, she was a technical officer in the NCD's management unit at WHO headquarters in Geneva. Dr. Ginsburg has led and co-authors more than 100 publications, including articles and commentaries in very high impact journals such as Lancet and many more, which I'm not going to list here. In recognition of her contributions in advancing women's health equity, the George Institute for Global Health has been honored to confer on her the title of Elsa Atkin Distinguished Fellow. This evening, Dr. Ginsburg will talk to us about her experiences in implementing evidence-based strategies for prevention of cancer in women, in particular about how to bridge the gap in what should happen in theory and what happens in practice, not just to narrate the problems, but hopefully use this information to find sustainable solutions. After her talk, she will be joined by Professor Neerja Bhatla, who is a professor in the Department of Obstetrics and Gynecology at the All India Institute of Medical Sciences, New Delhi. Dr. Bhatla is, of course, an expert in all aspects of obstetrics and gynecology, but she has a special interest in gynecological oncology, or cancer related to gynecological specialty. And she has undertaken numerous research projects in this field, in particular on cervical cancer prevention in low resource situations, in collaboration with many organizations, including the International Agency for Research on Cancer at Lyon in France, and the Johns Hopkins Bloomberg School of Public Health of US. Professor Bhatla has an impressive body of work in cervical cancer prevention and has led the cancer practice recommendations from the Federation of Obstetrics and Gynecological Societies of India. She has held numerous positions, including the chairperson of the Gynaecological Oncology Committee with the International Federation of Gynecology on Obstetrics. I welcome you both, Professor Bhatla and Dr. Ginsburg. And Dr. Ginsburg, the Zoom screen is yours now.
Thank you so much. Thank you for that very kind and warm introduction, Dr. Jha. I'm just going to share my screen. It's truly my pleasure to be here, and I only wish we could do this in person, but perhaps another time, and soon we'll all be together in person. So this talk is called Lost in Translation, Evidence-Based Strategies for the Prevention of Cancer in Women. Just want to make sure that everyone can hear me and you can see my slides.
Yes, we can.
Thank you. I have nothing to disclose except that I am actually Canadian. And that does inform some of the content. So I'm going to start with Professor Hans Rosling, who many of you know. The unfortunately late Professor Rosling was uniquely suited to describing important trends in population health and helping folks like myself and people across the world understand what the true trends were in opposition to what we sometimes believed, such as what the direction was in terms of how many people are living in extreme poverty and maternal mortality rates, which continue, thankfully, to go down. And one of the quotes from his last book before he passed away was called Factfulness. And for those of you who haven't read it, I highly recommend it. And I consider this a way to frame minding the gap. You know, he called it factfulness as recognizing that a single perspective can limit our imagination, and remembering it's better to look at problems from many angles to get a more accurate understanding and find practical solutions. So to control the single perspective instinct, we need a toolbox, not a hammer. And I'm going to come back to this later in the talk. Now, speaking of numbers, cancer by the numbers, just to give you a few basic statistics from IARC, from the International Agency for Research on Cancer. This was the last version, the 2018 data for global cancer statistics. We see there were 18 million new cases and sadly 9.6 million deaths. About 1 in 5 men will develop cancer, 1 in 8 will die. For women, it's about 1 in 6 and about 1 in 11 when women will die of cancer. But what's most important for this talk is that the majority of new cases and new cancer deaths are occurring in Asia, Africa, and Latin America. And moreover, most of the increase, the rapid increase, 70% increase in the next 20 years, are expected to happen in low and middle income countries. So why is this? And how does this relate to women's health and women's health equity? How can we translate what we do know into policy making? And more importantly, taking the policies back to the ground where it matters to impact population health. And that's the focus of this talk. So why do we see increased risks of cancer for women in particular? Well, in general, about 30 to 50% of all cancer cases are preventable. And 22% alone are due to tobacco. And I'm sure most people who are watching this now are aware of this to some degree. But many people, I think, have a misconception about where cancer happens, as I said, largely in low and middle income countries at a much more rapid rate, which is consistent with the rise in other non-communicable diseases. And I choose this photo for a reason. I took this photo in Vietnam, in Hanoi, not far from where the now older campus of the National Cancer Hospital is. And you can see here that in the front is the only woman on a bicycle, and there's a sea of motorcycles behind her. This has been a transition that I personally have witnessed over the 15 whatever odd years I've been going to Vietnam. And increasingly we see very energetic, youthful population with smartphones and motorcycles. And oh, there's a little bit of an echo. And we see fewer and fewer women and men who are on bicycles. Now that's a sign of improving economic advancement, because unfortunately, I think this woman probably would want to have a motorcycle, but also the impact of outdoor air pollution, the impact of more sedentary lifestyles, et cetera. And for women, this is particularly dramatic. In fact, if you look at both sexes, all ages, pink being breast cancer, you can see that breast cancer is the #1 cause of cancer among individuals regardless of sex in 104 countries. When we look at women only, we see that breast cancer is by far the most common. In this case, this is age standardized incidence rates. So in 156 countries, breast cancer is the #1 cancer. But when you look at mortality, what do you see? I'm going to go back to the first slide. First of all, here's breast cancer throughout most of the high income countries and upper middle income countries. And you can see here in orange, this is cervical cancer, which has the highest age standardized incidence rates still in about 27 countries, largely in sub-Saharan Africa. When I switch to age standardized mortality rates, we see a big change here. But before you look at the blue, I want you to look at the orange. This is cervical cancer, which is still the #1 cause of cancer-related deaths in women in more than 40 countries. That's appalling. This is a completely preventable disease. Cervical cancer takes the lives of more than 300,000 women per year, which is now greater than the number of women also, sadly, tragically lost to complications of pregnancy and childbirth. When we look here at the blue, what do we see here in North America and Australia and China and much of Europe? We see here that lung cancer has overtaken breast cancer as the #1 cause of cancer-related deaths in women. So that's another tragedy that's also preventable. And it's something that also reflects the improvements in the treatments, early detection and treatment for breast cancer in the countries where we see this. So it's a combination of factors, and we need to understand this better to be able to inform our policy making. In the case of women, because this is the only time I'll mention tobacco, I know, for example, it's recent news to me that in India, it's not only, of course, cigarette smoking, but in the case of women, it's the use of smokeless tobacco products that is such a huge burden in terms of oral cavity cancer, as well as other cancers. So this is an equity imperative. This is a slide unfortunately, and this is the only slide I'll use with something really unpleasant. You can see here on the left side, that's a breast cancer, invasive, tiny, less than 1 centimeter. This is in Canada, it's a digital mammogram. And that woman is probably, being an average person with breast cancer in Canada or the US or the UK, she's probably about 60 years old. She probably has hormone receptor positive disease. Not too important today, but for those of you who know something about breast cancer will understand This is probably an early stage, highly curable cancer with surgery, lumpectomy, radiation, probably tamoxifen or another type of hormone blocker. She probably doesn't have any lymph nodes affected under her arm. This is a type of photo that you see very often in the clinic I used to work in Bangladesh, where the cancer is already advanced. It's called locally advanced, but in fact, she probably has microscopic metastatic disease, and it's very hard to treat, harder still to cure. In the case of cervical cancer, the inequity is incredibly stark, but I also want to demonstrate something here by region. In Asia, Asia includes most of the world's women who have died of cervical cancer in 2018, and Africa here, 26%. Now, this is a feature, of course, of the population size, but when you look at it another way, almost 9 in 10 women who die of cervical cancer are living in a low and middle income country, and many of these women are in Asia. In fact, India alone has the largest number of women of any country, in fact, all of Africa combined, of women who are dying of cervical cancer. And it really shouldn't be this way. And in fact, Dr. Tedros in 2018 called for the elimination of cervical cancer as a public health concern. I'm sure many of you know about this landmark declaration. And in fact, the resolution was just passed at the World Health Assembly, which brings together member states' commitments to advance this action. Cervical cancer strikes women in the prime of life. This is the other factor that often isn't considered when we talk about cancer in women. Breast and cervical cancer in low and middle income countries. The photo I showed you from Bangladesh, that woman was probably about 42, which is much more typical in low and middle income countries. It's affecting women in the prime of life. And it doesn't have to be this way. Cervical cancer, for example, is really one of the most preventable and treatable forms of cancer, as long as it's detected early and is treated properly. And the strategy here was partly modeled, not modeling in the statistical sense, but well, it was, but also modeled in the colloquial sense after HIV/AIDS targets to try to have something aspirational we could get our heads around. 90, 70, 90, a global strategy, right? So efforts must be aligned and accelerated with the following targets: 90% coverage of HPV vaccination, 70% coverage of screening, with most women being screened with a high performance test. I'll come back to that when we talk about the evidence between the ages of X and Y, 35, 45, et cetera. And most importantly, treatment of precancerous lesions and management of women with invasive cancer. All of this is necessary to eliminate cervical cancer. And I say this for an important reason. You know, how are we going to get there, right? So here's the mortality impact of achieving the cervical cancer elimination targets, just one of many superb modeling analyses by this group, the 3 co-lead authors. Here's Dr. Karen Canfeld, Jane Kim, and Marc Brisson, who have put together extremely important data to estimate when we think we're going to get to that elimination target. But how are we going to get there, right? So these findings emphasize the importance of acting immediately on all 3 fronts: scaling up vaccination, screening, and treatment, right? And in the next 10 years, a 1/3 reduction of the rate of premature mortality in LMICs is possible, which would contribute to the realization of the 2030 UN Sustainable Development Goals. And over the next century, if we could do this, we'd reduce cervical cancer mortality by almost 99% and saving 62 million lives, right? Before I come to breast cancer, I will say this. Just think of this, right? Think of what this means, right? Think of the relationship between HIV/AIDS. HIV, women living with HIV are at far greater risk of developing and dying of cervical cancer. There's a lot of data coming out now. WHO has new guidance, which we perhaps will talk about a bit more in the Q&A. But it's important to remember that unless governments actually prioritize the elimination and are able to operationalize guidance to get there, we are not going to be able to achieve this. And so where the rubber hits the road is really what we need to talk about now. In the case of breast cancer, I think it's important in a way to toggle between these two, because they are taking the lives of so many women with cancer each year. And I think people's hearts and minds are a little bit more focused on breast cancer in many countries because the numbers are greater. And we've had celebrity endorsement in many places, including, I'm sure, in India. We do have guidance. We have the Guide to Cancer Early Diagnosis, which breast cancer is sort of an exemplar for. WHO guide in 2017. I was fortunate to be involved in the development of this while I was at WHO. The position paper on mammography screening, which is from 2014, but still very relevant because it talks about what you need in terms of your health system, infrastructure, and other requirements to be able to take this to scale. And it's so much harder than people realize. And that's going to be a message of today as well. And the IARC Handbook of Breast Screening. So we actually know what to do, right? But how are we going to get there? How do we overcome this no-do gap? And I'm mentioning here 3 seminal papers that informed the US National Institutes of Health roadmap, published in the New England Journal in Science and in JAMA. And I feel like today I'm really standing on the shoulder of giants. First of all, of course, Dr. Ved, who executive director of the National Health Systems Resource Center and was the last year's professor who gave this lecture. And in a summary about her talk, which is on the George Institute website, she talked about translating evidence to policy requiring a broader understanding of health systems, right? How to integrate community health with larger health policy. How do you understand that NCD implementation in health systems is much more complicated, but in some ways more simple than we think, right? Think about the capabilities that we have of using the data and the evidence for policy making. And she specifically was speaking about reviewing the literature and sharing the knowledge. Another giant I want to quote today is Dr. Verna Vanderpoy, who's at Korle-Bu Teaching Hospital in Accra, Ghana, and I'm fortunate to call her a colleague and a dear friend. She is also the co-chair of our new Lancet Commission on Women in Cancer that I'll mention at the end. She's currently the treasurer of the African Organization for Research and Training in Cancer. For those of you who are unaware, this is a very important, increasingly important organization that many of us who live outside of Africa have the good fortune to participate in with meetings and also with trainings and other efforts to advance the research in order to inform best practices in many different settings throughout Africa. She gave a talk recently where she said something so simple and beautiful about her own clinic, as she is a clinical oncologist. She says her patients regularly tell her, "You have to understand me to help me," right? So this, I think, is an important lesson for all of us and for myself, not just me, the me being the patient, but the family, the community, and the society at large. We have to understand all of these elements in order to actually make an impact. And a little sidebar here, which I think is very worth mentioning. Dr. Richard Sullivan, Professor Sullivan, who's at King's College London and the director of the Institute of Cancer Policy, Dr. C.S. Pramesh, who many of you know is the director of the Indian National Cancer Grid based at the Tata Memorial Cancer Center, and Dr. Chris Booth, who has spent a lot of time in Kerala, actually from my alma mater, Queen's University in Canada, teaching about health services type research. They have produced a comment here in Nature last year that looked at, in fact, they're quoting this study, but they're looking at this problem of everything being considered in terms of the technical advances. So this is a problem for a bunch of reasons. For those of us who advise ministries of health in low and middle income countries, often we get met with the argument that cancer is too complicated. We will get to cancer eventually, but now we have to focus on maternal health. Well, remember what Hans Rosling said. Is maternal health already going down because of a lot of good practices and policies? Not that it can't be greatly improved, greatly, including in North America and Europe, where we still have great disparities in who is dying in childbirth. But in fact, cancer is a priority, and it should be a priority, and it doesn't necessarily take high technology in order to achieve better outcomes. So of the 277 cancer drug therapies in which clinical trials were published between 2011 and 2015 in an analysis in the Annals of Oncology, only 15% of those treatments led to meaningful improvements in patient survival or quality of life. And most of those treatments are unaffordable in most countries. That's until 2015. In the last 5 years, there's been an explosion of precision medicine, of targeted agents that take advantage of the molecular features of a tumor to improve outcomes for selected patients. And I will not take away for a second the importance of those advances in research and the importance for the patients who do improve, for those patients and families. But in fact, when you look at population level, we're not really there, right? Less than 5% of patients in low-income countries, in fact, have access to safe surgery, affordable, timely, effective cancer surgery. And for middle-income countries, it's not much better. It's only about 22%. And so in this paper, they draw attention to the fact that in emerging economies, we have a chronic underuse of therapies that can save lives, such as cervical screening, basic surgery, such as for breast cancer, and even radiotherapy, which, although the machines seem expensive, they pay for themselves over time. And there's a Lancet Oncology Commission on radiotherapy that I can draw attention to later if people are interested. But in emerging economies, we have a chronic underuse of therapies that can really save lives and a chronic overuse of interventions at huge expense to patients and to the country as a whole, providing in many cases, sadly, no meaningful clinical benefit. I also want to draw your attention to the Action Study Group, and I believe that the George has had a large role to play in this. 75% of people who were tracked after 1 year after diagnosis of cancer, regardless of cancer, from a number of countries in the ASEAN region, 75% had either died or experienced financial catastrophe at 1 year. And so that is quite dramatic and telling. So how is this happening? Why is this happening? Even in countries where there is universal health coverage, what is being covered and what is being prioritized? And the last comment in this regard, I would be absolutely remiss if I didn't mention my amazing friend and colleague, Dr. Bishal Gyawali. For those of you who don't know Dr. Gyawali's work, he is a powerhouse in terms of publishing important commentaries and also doing the research to support the evidence, which is being discussed in high impact journals. He is still in his first few years on faculty, I'm proud to say, at my alma mater at Queen's University in Canada. But Dr. Gyawali hails from Nepal and eventually did his training in medical oncology and a PhD in Japan, and then went to a postdoctoral fellowship at Harvard. He talks about the cancer ground shot, going global before going to the moon. And I will say this, full disclosure, I actually am fortunate to share a Cancer Moonshot grant, but you know, the Cancer Moonshot initiative is absolutely brilliant, and I commend the incoming President Joe Biden for putting this together under the Obama administration. Tremendous funding for important cancer research. But in fact, when we look at what we already know, including cost effectiveness data, right? Best buys according to the WHO, such as vaccination against HPV, cervical screening, coupled with effective treatment for precancer. This is a ground shot. And we could do a lot. We could do so much good if we could get this right, the implementation of the policies that are already in our hands. In terms of breast health, what some of you may not know, there's something called the Breast Health Global Initiative, which was founded by Dr. Ben Anderson at the Fred Hutchinson Cancer Center in the US in Seattle, University of Washington, and he's now a consultant with the WHO, working in the area of resource stratified guidance for breast health. And the most recent summit I had the good fortune to participate in 2018 as the co-chair for the early detection work group, based a lot of our work on this guide to early diagnosis of cancer with the following sort of provisos. Early diagnosis, of course, increases the chance for successful treatment by focusing on detecting symptomatic patients as early as possible, right? Note, early diagnosis, not screening. Screening is something entirely different. Screening involves a large population at risk, right? Looking for asymptomatic disease. I'm sure most people on the talk know all about this. But it's an important distinction that's sometimes lost when we're talking about how to make rapid improvements in breast cancer survival and breast cancer mortality in lower resource settings. And this is what I'm going to speak about now. Not to go through each slide in lots of detail, but to give you a gist of what is in the guide and what is in a series of papers published in the journal Cancer this year that took us through the aspects of the summit, which was focusing on health systems and on a stepwise, phased approach to implementation of evidence-based policy for breast health. Simple as this: awareness and accessing care. Of course, there are many facets to this, right? Women have to understand what breast health is about. They have to recognize when they have a breast symptom that needs to be followed, to be investigated. But they also need to be able to access care by somebody who can recognize that it is a problem and they may need diagnostic intervention. You'd be surprised how much could be done just by getting that right. Primary care, education, informing the public and providers of primary care. Looking at the barriers at each step for health literacy and cancer stigma, and limited access to primary care, as well as limited knowledge of primary care providers, or at least limited capabilities that they may absolutely know that there's something wrong, but they don't know how to get from A to B, how to help navigate or encourage and facilitate a woman's journey throughout the clinical care pathway. Those referral linkages need to be strengthened in most settings. This is a complicated slide I won't go through in detail, but just to let you know that this is described beautifully in the summit, the main summit publication that goes through the methodology in three sort of buckets. They call this the patient interval. I would prefer it the pre-diagnostic interval, so it doesn't so much blame the patient. The diagnostic interval, and you can see these as gears, right? Scaling up pathology services. In fact, in many ways, that's the rate limiting step. If you don't have access to high quality pathology and communication between the pathology unit and the providers providing care, communicating to the patient the diagnosis, then the rest of what you're doing doesn't make much sense. And certainly, most importantly, for our purposes, talking about early detection, in this case, management of clinically palpable disease. If you can't assure that all women who have a serious breast problem, a mass or a nipple discharge or a finding that could be breast cancer, that they cannot have effective, equitable access to affordable diagnostic services, then we have no business talking about population-based breast screening. So how do we do that? Well, there's a situational analysis toolkit that was developed by the BHGI collaborators, funded by the Komen Foundation. There's examples of metrics you can look at and track. Won't go through this in any real detail, but they start with community-based awareness. What percentage of the population are aware of breast symptoms? Percentage of the population knowing where to go if they have a symptom, right? Provider awareness about breast health, and then going down the list, what is the percentage of patients with breast cancer diagnosed early at stage 1 or stage 2, right? This is the resource level. And some people may argue, what are you talking about? Shouldn't everybody have the best possible care in terms of diagnostic evaluation? Shouldn't we all have access to a PET CT? Well, in a perfect world, the answer would be yes, but we live in reality. And in reality, going back to the ground shot or earth shot, it helps to actually look at what you have. So that situational analysis is not meant only for countries as a whole, and it has been used effectively in several countries, including Tanzania. I was lucky to participate in some of the Evidence2Policy work with the toolkit informing the guidelines with that country's Ministry of Health. But to look at the subnational resources, even if you have a very high quality tertiary care facility in an urban center, if most of the population lives hours and hours away and they live in poverty, well, we need to look at what they have closer to home and how we can improve, right, care at primary care and at secondary level of care. Because most women, for example, with a breast mass will not have breast cancer. And you can spare them traveling for a day, perhaps leaving their families, leaving their jobs, etc., to come, and unfortunately also taking up sometimes a lot of room in the waiting areas in overcrowded tertiary care facilities for a problem that turns out to be benign. So a lot can be done by bringing this care closer to home. We can talk about this in much more detail. Basic, core resources and enhanced. This was set out in the Breast Health Global Initiative, and there's lots of publications on this I can guide people to. The implementation roadmap for improving breast cancer outcomes comes also from this series, which I don't need to go through in detail, but for those of you who are interested and are thinking about supporting research institute or a government. So I work closely with JPIGO and especially the India office. I'm going to speak to some of that in a moment. We really look at this, and we're using this process to serve some of the needs of the program that in Jharkhand State and UP, where we've been asked to support their efforts in breast health. So establishing reliable systems to stage and identify cancer subtypes. This is something that speaks a bit more to the importance of quality pathology, which often gets missed in discussions about public health and cancer control. Recognizing it's unacceptable to offer treatment without knowledge of these. What are we talking about here? Simple. Is this tumor ER estrogen receptor positive or negative, right? If it's positive, we might be able to offer that woman a very inexpensive, widely available generic medication called tamoxifen that alone can reduce mortality, can reduce death from breast cancer in many cases by 30%. We have loads of data, hundreds of thousands of patient years over time. It's not new, it's not sexy maybe, but it works. And guess what? Tamoxifen can be considered the first targeted treatment for breast cancer, although we don't think of it that way. We should be able to provide this basic pathological service. And there's new technology that's coming along that may help us do that in a decentralized fashion that's less operator dependent. So lots we could unpack. Designing a resource stratified phased implementation strategy for breast health services in India. This is the paper that came from our initial work. I say our, I'm lucky to be part of it. This is led by JPIGO's India team, Somesh Kumar, MD, PhD, who is now based in Baltimore with headquarters for JPIGO, but was in Delhi for most of his career, and his team. And they used the BCI 2.5 toolkit to assess breast health services in 2 states. This is published in the journal Cancer alongside that series from the recent summit of the Breast Health Global Initiative. They struck a technical advisory committee and groups. They worked with the state departments of health, as well as the tertiary facilities in both those states to look at what was happening at primary care, what was the knowledge and understanding, how were the ASHAs, for those not from India, the community health workers being engaged to educate the community about breast health and guide women to the nearest facility where they could get evaluated. And so they mapped all this out in a lot of detail. And here is a little bit of data from this paper from the 2 states in a year of effort that included developing a toolkit, like a keychain sort of handy guide with pictures to represent basic aspects of breast health to educate the providers and then educate women in group settings and door-to-door settings. And they enumerated 105,000 women between the ages of 30 and 65, as this is the Government of India's strategy as part of the 5 NCDs program: breast, oral, cervical cancer screening, diabetes, and hypertension. Focusing on breast health, we had 105 women enumerated and encouraged to come for screening or to come to see the provider at the health and wellness center, or here it was a sub-center as these were being developed, if they had a breast problem. So to some degree, it also included case finding. 25,000 women actually did come, of which 1,534 were found to have a breast problem that needed further evaluation, which is about 6%. 685 then made it to the next level of care and had a confirmatory clinical breast exam by a specialist. They were able to have an ultrasound, as this was all set up in advance. But for those who needed additional evaluation, meaning a biopsy, well, they had to come back, right? And so here we see a big drop-off of women with initial findings of a clinical breast exam that was abnormal, and only 685 came. And then again, we have, that's about 45%. And then we have only 431 434 of 685 were found to have confirmatory testing, which speaks to the quality of services, because actually the provider at the subcenter did a very good job of evaluating, doing a good job of doing a clinical breast exam, because most were confirmed by the specialist. So that's a little piece of information that's also very important. And the concordance between the primary care provider and the specialist got much better over time, which I'm not going to show today. However, only 322 of these women underwent the final diagnostic evaluation. We don't need to talk about how few women are found to have breast cancer, except to say that's what you'd expect in breast screening, especially if you're starting with women who, in my view, are too young to have breast screening. But this takes a lot of effort to find very few, and yet many came. They learned about breast health. We can think of this as a breast health education initiative as well. But look at the percentage of people who are falling off, who don't have adherence to the care pathway. This is an area of great importance and something we're working on the research side. We've just submitted a grant to try to get at why this is the case and how to improve equitable access, how to improve women making it through their care pathway. And this brings me to a topic that's very close to my heart, is about equity across the board. So who are the women who are less likely to access care? Who are the women who are less likely to utilize care if it does exist, and even if it is affordable in any setting? It's the same groups. It's marginalized women. It's women who have disadvantages, whether they're social, economic, based on their minority status, ethnocultural status, or migration status. We put this together in a series in The Lancet a few years ago with about 40 authors from 18 countries, excuse me. And it included 3 papers, one which was on stating the case, showing the burden, et cetera, in a lot of detail with data from IARC, with my colleagues at the International Agency for Research on Cancer, as well as the Cancer Survival Group at the London School of Hygiene, and many others. We also looked at all the interventions, we looked at the cost effectiveness, and we came up with a set of recommendations which ultimately informed some of the policy that we've talked about today. But I'm going to draw your attention to this one. This is a commentary that came alongside the series that we published, and it's by Michelle Bachelet. Dr. Bachelet, at the time, was the president of Chile. We wanted to have a female head of state to make a commentary on this topic, and she called it Women, Power, and the Cancer Divide. We think this was very important as part of the process of publishing this, to get these bite-sized pieces of information to get the attention of policymakers, and speaks to the importance of communication, right? Everything from communicating with our membership in communities, right, at ground level, understanding what the lives are like for women we're trying to serve. You have to understand me to help me, right? Likewise, we have to understand what is going to get the attention of policymakers, and especially in the Ministry of Finance, not just the Ministries of Health. Ultimately, we had a few major comments on where a woman lives, her status, et cetera, should not mean the difference between life and death from these common cancers for which cost-effective life-saving interventions exist. And we want to mitigate these cultural and social attitudes that do play a role, embedding a gender perspective, and we needed active engagement from political and health leaders, civil society, global health funders at domestic and international level. So coming back to that toolbox, how do we get there? Well, we talk about policy initiatives, cancer literacy, health promotion, looking at the targets for HPV, but also, by the way, women also need to be vaccinated like men, and obviously in childhood for hepatitis. It's a major cause of liver cancer. Capacity building, task sharing, et cetera, health system improvements. All of these things are important. I won't go through this now, but to say that this diagram that is unpublished but is based on a paper I worked on with the head of genetics at IARC and others, Dr. Paul Brennan and others, Nature Reviews Clinical Oncology. We looked at a population health equity framework for, this was genomics and cancer prevention, but here I'm looking at global cancer prevention and control as it pertains to women, starting with knowledge generation at the left-hand panel, knowledge integration and the research that informs and goes 2 ways, right? The iterative process from, especially with implementation research, that feeds back into the population science, knowledge dissemination, including M&E, which of course is critically important in every setting, capacity building, the use of telepathology, telementoring. COVID has taught us a lot about how far we could go backwards in time, unfortunately, with poverty, maternal health, and also with cancer screening, and even the risk now is to the acceleration we were about to have, we thought, on cervical screening. We don't want to have this setback, making the most of what we have in terms of telehealth and the impact on population health, right? Equitable access, utilization of these services, and what metrics are going to be important. Not just new cancers averted and cancer deaths, but also disability adjusted life years gained and discussions about patient reported outcomes. And you'll see here as this, based on the Blue Highways approach at the NIH, looking at the translational cycle of research, we decided to place high resource and low resource settings in a, well, not a circle, but in a continuous fashion, right? It's not unidirectional. This is something that we learn from each other. We learned so much from research being done in low and middle income countries that are very much applicable to high resource settings and vice versa. And the last couple of seconds, I just want to mention the Lancet Commission. I said at the beginning, we're fortunate to have collaboration with the George Institute. In fact, the George Institute India with Dr. Devaki Nambiar is one of our commissioners, which is just wonderful. The purpose of the commission is to advance an evidence-based gendered approach to cancer risk and cancer control. And we'll address urgent questions at the intersection of social inequality and cancer risk, as well as cancer outcomes and the status of women in society. And I thank you for your attention.
Thank you, Dr. Ginsburg. That was a really insightful presentation. I will now invite Dr. Neerja Bhatla to join us and kick off the fireside chat with Dr. Ginsburg. Over to you.
It's been a great talk, Ophira. It's been really nice. You know, we've worked on many little things together. Our paths have crossed so many times. But I think today it has been really insightful listening to you and to all the people who are in the audience as well. And I see some very old friends in the audience who have been committed their entire lives almost to the task of cervical cancer screening. And I can say one thing that, you know, we've reached a point where as clinicians, we realize that we have a lot of the tools now, but we don't really know that how to bridge that gap. And I think your talk really gave us a dive today into looking at other aspects and perhaps bringing us a little bit closer to understanding how many people we need to bring together to get something. And especially when you talk about the three-front approach, you know, it's the vaccination screening sort of go hand in hand, sort of, because they're both preventive, but one is the pediatricians and the community people, and then the other is the gynecologists, and again, the community people. But the treatment is a whole different group of people, and then the palliation. So I think it was really nice to see all these various aspects, but again, a little sad to see how much of the inequity is there. And while you mentioned cervical and breast both, but I think breast is something which still gets the eyeballs. And I remember when I was in South Africa with Lynette Denny, she would say, oh, everybody loves breast. Everybody is ready to run for breast. Cervical cancer, no one wants to talk about. So I think it was a really great day for us when Dr. Tedros really put that spotlight and said, we have to work on cervical cancer and we have to eliminate it. But talking of this strategy, which you talked about, the WHO 90, 70, 90, we've got this three-front approach. And yet we have an accent on saying that we should get HPV testing in for the 35 and 45-year-olds. What is your comment about really the applicability of the strategy to the countries we talk about? And do you think it might actually make them more despondent and make this inequity gap worse?
Thanks. That's actually a great question. First of all, I share your concern that for those of you who don't know, what we're talking about is the highly effective screening, as mentioned in the 90, 70, 90 approach for cervical cancer elimination. the highly precise types of screening are best done with something using HPV DNA. Okay, so this is still unaffordable. This strategy and these tools are still unaffordable in many settings, even though we have excellent cost effectiveness data that's very favorable. Cost effectiveness is not the same as affordability. So what does that mean for the people at the highest risk are living in the poorest countries, or they are less advantaged even in higher resource settings and less likely to have access to this highly effective screening. I would say to you that we haven't been angry enough. We haven't been vocal enough. Maybe angry isn't the right word, especially in the current climate, but we shouldn't be complacent, and no is not an acceptable answer. No, when companies tell us this is how much it costs to manufacture this, right? Look what was done in so many other areas of health, in particular, the HIV/AIDS community, where the community advocates and activists partnered with the scientists. Can you imagine? To get the costs of those medications down so dramatically in such a short period of time. Not short enough, unfortunately, but it happened. The same should be happening for HPV-based screening tests. Unfortunately, there's a lot more in the market, not in the marketplace, but in the pipeline now in terms of development, including in India, where there's so much innovation in health technology. And so I think that this is really going to, happen in the near future if we all come together and do a better job in terms of public-private partnerships or other ways to convince, whether it's philanthropic or otherwise. I would prefer that it's done through the types of business models. That's definitely not my area of expertise, but I understand that these things are possible and they've worked for other health conditions. So why not cervical cancer? This is absolutely a neglected disease. For 300,000 women a year dying, it's just unacceptable.
Yeah, I agree with your story about HIV, and it came in from out of the blue, and we rallied and we understood it, and there was so much advertising, everybody suddenly knew how to do it, and you had the centers and you had whole commissions devoted to it, and we managed to get our heads around it. And with COVID, in fact, the response has been even quicker to develop diagnostics, to develop a vaccine, not a vaccine, many vaccines, to develop the capability in India, for example, to manufacture so much PPE where almost none existed. It's been phenomenal, and it shows us what you can do if there is political will. But what do you think about the impact of this pandemic on our prevention efforts, and what is really going to happen now?
I'm going to first just to address what you said at the start of this is the question of, we now have a great example of how when the world comes together, or at least when science is well funded and there's a mandate, look what can be achieved. It's incredible, truly incredible what's happened with the vaccines. However, to be a little bit cynical for a moment about why that happened, it's also because the people who are funding the research and the countries where much of the research has been happening, those individuals, right, and communities are directly at risk from the SARS-CoV-2 virus, from COVID. And so it's an immediacy. It's a public health catastrophe that we can see. In the case of cervical cancer, we might think of it as a slow-moving pandemic. That is what this disease has really been over the last 20, 30, 40 years. The rise in cases and the spread of the oncogenic types, the cancer-causing types of HPV. And in fact, it's a syndemic alongside other health conditions. But we haven't done a very good job about emphasizing that. And because most people who are dying of cervical cancer are not people making decisions at the high levels in terms of global strategies and research financing, I'm not alone in arguing that that is one of the problems. And so one way to argue to get people interested is to appeal to the hearts about the equity issue, but the other is to look at the economics. So when you're looking at a country such as India that has a certain, limited amount of funding that can go towards health. And I think there's a lot more funding going towards health now. In many countries, that's not the case. Health is not prioritized. And when it is, it's only when there's something like a pandemic and they realize public health is important. But there's always going to be competing health priorities. And I fully accept that. Children need to be vaccinated for all the childhood diseases, and mothers need to be protected from preventable causes of maternal mortality. But if you can appeal using an investment case, and the WHO has been really great about this. You can look online now and get a toolkit to help guide a country through how to see it as an investment in the future, right? Lives saved and money saved by small investments now in this condition. This can be helpful. To your question about the pandemic itself impacting cancer prevention and screening, this is a huge problem. And there's a lot being written on this now. I'm actually part of the global COVID and Cancer Global Modeling Consortium that's led by Dr. Karen Canfeld, the same person I mentioned earlier, the scientist doing all that great modeling work on cervical cancer at the University of New South Wales. She and her team on the modeling consortium are taking a very close look and trying to help predict, to inform policymaking almost minute by minute and also into the future, because sadly, even with the vaccines, we're going to be dealing with this for some time to come. And also, sadly, it's not the only pandemic we're likely to experience in the coming years and decades. And so understanding the data is critical, and looking at how we can mitigate the backpedaling on some of these targets. So for example, HPV, right? Back to that HPV-based testing can be done with self-testing. They're self-testing. This is a fantastic invention that sadly is still, again, too expensive for many countries. We need to do what we can to help implement strategies using this technology so that most women are going to test negative. They don't need to come back. They don't need to come in for a GYN exam if they have a negative HPV test that they could do at home. This is an opportunity. COVID is calamity. It's also an opportunity to help leapfrog, to help use telemedicine to virtual care, which is being done to an extent none of us thought was going to be possible. Suddenly we're able to do it, right? When we put our minds to it. And so we should be able to mitigate the risk of sliding back on the prevention and screening side with better information and advancing some of these strategies that can take advantage of the hands-free type of screening, for example. I think you're on mute, Dr. Bhatla.
Yeah, we look at Africa, we look at Asia, and we see low middle income countries, and we see a lot of women who are facing the same problem at the end of the day, which is that they're not receiving screening, they're not receiving healthcare. But if you go down into the deep details, you see that while the problem is the same, the solutions in each place need to be individualized to that region, to that culture, to the levels of literacy and so many things. And what are some key lessons you have learned from your work in these communities that you think is more universal than others?
Oh, that's a great question. If I understand correctly, you're asking what's been effective in terms of engaging Correct. Communities, or in terms of tailoring strategies to the needs of the community members. Well, number one, again, taking from, actually, this goes back many more decades than the HIV/AIDS crisis, but then it was used as an advocacy tool. Nothing about us without us. Engaging communities directly, either by stakeholder meetings, community-based participatory research, which I would say I've been guilty in the past of being, very biomedically oriented and trained that way as a quantitative type person. It took me a long time to realize the value of that. And I'll give you an example. When I worked in Bangladesh in the early days, maybe 2009 something, we'd been asked to bring a clinical trial for women with advanced breast cancer that would be actually effective and also inexpensive, and I believed in what we were doing, and it was a good idea. But once we started working with our cancer team there, we realized this is in rural Bangladesh, in Khulna, which is maybe 200 kilometers, I guess, east of Kolkata. And we realized that, my goodness, they need a lot more than just this clinical trial. I mean, that sounds so obvious now, but what else is going on? In fact, my colleague there, Reza Salim, who's had an NGO called Ahmed Ergram, Our Villages, teaching poor women and men how to use computers, computer literacy in these villages. It was great. His organization already had lots of trust in the community because they were based there. They're from there. Fine. He asked us, why don't we do something in breast health? Why don't we start educating people about breast health? And this happened around the same time. It led us to form a small clinic called Ahmed Ergram, Our Villages Breast Care, right? But women still weren't coming. And so the question, I have slides on this that say, if you build it, will they come? And they didn't. So why didn't they, right? Were they just ignorant? They didn't know? Well, we then interviewed women who'd come with advanced breast cancer and asked them, when did you know you had a problem? Oh, did you know you have a problem? When did you know you had a problem? And somebody said there at the time, these women are poor. They're not stupid. They absolutely knew there was something very serious happening. They knew it could be life-threatening. In fact, they thought it was a death sentence. And why wouldn't they when you've never met anybody who survived breast cancer in your community, right? Cancer really effectively could seem like a death sentence. And they also had a choice whether to put their small amount of money that they had to buy books and school supplies and uniforms for the children to go to school. And the government's telling us that the education of especially girls is so important. Girls and boys have to go to school. Of course, these are good choices they're making. They're making decisions. But moreover, some of the decision-making about their own health wasn't their own decision. It's mother-in-laws, it's family members, it's male relatives, et cetera, who are driving some of the decision-making. We would never have known all of those elements that were preventing women from coming in for care earlier with a serious breast problem had we not asked those questions, had we not listened to the women themselves. That then helped inform research strategies, which I like to think have made some impact in that community and beyond, and informed other research I did later. I would never do any kind of research like this without going to the communities directly and getting buy-in also from community leaders, including religious leaders, which is also what we did there, going to the imams. So talking about breast health and cancer publicly became absolutely acceptable only after they said it themselves.
Yes, so it's so important to understand. But tell me, when you've done your projects, have they always been like breast health alone or cervical health alone, or have you actually brought them together to do them together?
Yeah, great question. Of course, you're quite right. And what I didn't mention in the talk is that another way to leverage resources and leverage capabilities we have already, part of the cancer ground shot or cancer earth shot, is to combine breast and cervical health services, of course. And in India, this is what the government wants us to do, the cervical, breast, and oral cancer even. And so there have been many good successes. The PEPFAR funded projects from the US government, the US agency PEPFAR, that was started as HIV/AIDS and led to cervical cancer opportunities for cervical screening, because women with HIV are more likely to develop cervical cancer. They then brought in breast health. And so in many countries that have had PEPFAR funding, they've been able to work in settings where women are receiving care for HIV to have cervical screening and breast health evaluations and breast health education, which is, of course, a win-win. It needs to be done. And my projects now include as many things as possible that you can fit into a project to leverage the opportunities and the benefits to patient care.
Yeah, I think in India, what happened was that we did have a national cancer control program on paper for a long, long time, but it was really not going anywhere. And then came this whole decision from WHO to put all the communicable diseases together, and cancer got lumped as well with heart disease and stroke and everything. And everyone's like, oh, and we're never going to get anywhere now. But in Tamil Nadu, the southern state, which started off the first, statewide implementation of screening, they did a fantastic job by identifying the NCD nurses who would be specifically for the blood sugar and the blood pressure, and looking at the breast examination, clinical, and doing the VIA. And patients who used to be so scared, because as you said, even if they had a tumor, they would live in denial because they didn't think it was going to be treatable. And they would say, if I have a cancer, I don't want to know it. And suddenly they were not so scared because it wasn't a cancer screening program and everyone can get a sugar test and a BP test. And so when rolled in, it actually worked out better. So sometimes you actually get surprises. And in fact, the situation now, because of a great deal of political will, you mentioned about maternal mortality. The situation now is that we have less maternal mortality than we have deaths from cancer, cervical cancer alone, leave alone the others. So it's almost become like you could save the woman out of the maternal mortality only to have her dying of this. And in cervical cancer, the women are younger and the years of life lost are greater than they are with some of the other cancers.
Absolutely.
So it's really a challenge how to keep the focus, because we know Tamil Nadu started well, but then now we're not really sure where the program is. But on the other hand, we do have a national program where we have almost 200 districts of the 700 who have got some degree of training. So there's great hope there. And let's see what happens. But again, it's this, we had a WHO CRO meeting last year, and there was great concern from the Bangladesh contingent that we've managed to get the VIA rolled out to a considerable extent. We have a whole network, we have the trained providers. And if we now go back and say the WHO only wants us to do an HPV test, they're going to just crash the VIA program completely. And then this will be a terrible story.
Yes. Well, the one thing I would say about programs that are based on VIA now is that I never think that all is never lost. All is never lost, because now you've created, if it's been effective, and I think in Bangladesh, they've made great strides in the last number of years, you've changed or maybe introduced a culture of cancer screening, right? Even that alone has value. This is an effort to inform the population that cancer, in many cases, and depending on the cancer, can be detected early and can be treatable or even preventable by simple methods. And the nurses who've been trained, or nurse midwives in many settings, and also community health workers and ASHAs, as we did in Bangladesh with the community health workers, are now themselves more aware and empowered, not just for their own health, but for their health of the women in their family. They become ambassadors for cancer care and control. I know these things are harder to capture necessarily, but the shift in consciousness is very important, just like the shift in norms of being able to talk about cancer and and to decrease the stigma. So I think there are other valuable aspects to having a VIA program, even if A, it's harder to scale up, and B, it may make things a little tricky when you start talking about HPV care. By the way, though, on a practical note, the nurses, midwives, et cetera, providers who are trained to visualize the cervix using VIA, they will still need to do some type of visual, of course, I'm talking to an expert, visualize the cervix for an HPV positive case to make sure that it's amenable to treatment, or a second step of triage, right? Yeah.
Reassured about that. I see some very interesting questions in the chat box, in the Q&A, I mean. We have a question from Surekha who says, intimate partner violence is a known risk for cervical cancer. Is there some way that interventions can look at them together and come up with more holistic and sensitive strategies and care?
Oh, that's a great question. Yes, the short answer, first of all, that's tragic. And just a sidebar again, back to my work in Bangladesh on breast cancer, we actually had a medical anthropologist working with us who ended up doing a PhD thesis on intimate partner violence and breast cancer. Of course, violence not being a cause of breast cancer in a setting, but the fear of violence, the fear of also abandonment and of family abandonment, being ostracized, was a factor that many women shared with us in preventing them from coming for care. When it comes to cervical cancer, I'm not sure I understand exactly what is meant by it increasing the risk of cervical cancer, unless you're talking about increasing the risk of exposure to HPV or other terrible health impacts of violence that can maybe alter the immune system, or certainly sexual violence, which can transmit also, sadly, HIV as well, and that as a cofactor like we've talked about. But the issue of sensitivity to those of us doing an interview or encouraging through health promotion strategies for women to seek to get screened, let's say for cervical cancer altogether or any other health issue, we should always be aware of the potential downside in terms of women identifying cervical cancer as a risk factor for intimate partner violence would be, I suppose, out of the concern that my wife has been unfaithful to me. And the fact that it is a sexually transmitted infection certainly does raise that, unfortunately, raise that concern. So we do need to be sensitive to this, and we do need to listen to the women's concerns, right? Is it safe? Part of any screening for intimate partner violence should be part of any healthcare interaction with women anyway. But that's not my area of expertise, obviously. Dr. Bhatla, what would you say to that answer?
I think
question?
It can be a surrogate, perhaps, for various other factors that may be the reason. I think the next question that we have is partly been answered already. Would screening for cervical or breast cancer be better implemented, have greater reach and acceptability as a focused program, or as part of a package of disease prevention, health promotion, and initiatives? Well, I think we've already talked about that, but then she goes on to ask Lakshmi, by governments or by NGOs?
Oh, okay. Well, certainly the concept of integration is, I think, what we were referring to without saying the word, integration of anything, certainly cancer services within primary care, reproductive health care, mainstreaming cancer, and not having it as another vertical or siloed program is absolutely critical. I think we all agree, and we want to learn from what hasn't worked in other health conditions. The question of also who is giving the care or who is supporting it, it's kind of related, because I would suggest that in other health conditions, and to some extent cancer screening services, when they are funded by external non-governmental partners, especially international partners, and I feel guilty of this too. We come in, we have funding, we do a project. How likely is that to be sustainable? How likely is that service going to be integrated into the healthcare infrastructure, into the health system of a given, and when I say government, I don't necessarily mean national government, but even a regional, state, et cetera. I prefer, and I think it's been shown, that working alongside as best as you can, either within the government program or alongside in support of, and certainly with real buy-in, not just somebody signed a letter of support, but real genuine buy-in, maybe with even in-kind, sharing the trainings, et cetera, of championing the effort is much more likely to be successful and scalable in the long term. Reporting on your findings also. In fact, with mHealth, telehealth, use of mobile phones, which is part of what I do as well, working with the Ministry of Information Technology, making sure things are HMIS, right? Health Management Information Systems compatible, that kind of level of engagement, even that is often overlooked as a strategy to encourage uptake of your program. We've done this in Tanzania, actually. My colleague, Dr. Karen Yates in Canada, and her team in Tanzania, we worked with the Tanzanian government, and now our mHealth intervention called CVIA, for smartphone enhanced visual assessment for the cervix, is part of the National Cervical Cancer Strategy, the CCAP program, 2020 to 2024. We're woven right in. Yeah.
I think the similar sort of question is there by Devki also, who says, What is the scope for working with women's self-help groups on building cancer awareness, screening, etc.? So I think you've sort of answered that, and she thanks you for your candor and depth, and she appreciates your talk. But we have one question about the growing burden of women's lung cancer in high-income countries. Should we be focusing on that as well in LMICs?
Oh, great question. In fact, I'm fortunate to say on our Lancet Commission, we have Dr. Narjas Duma, who is a medical oncologist in the US, excuse me, originally from Latin America. Her whole focus is on lung cancer in women. There is a big misconception that women don't get lung cancer. There are also real concerns about lung cancer among non-smokers. And in women, this seems to be a rising issue. Whether some of that is related to secondhand tobacco, or I'm not an expert in this area, but in the case of India and other LMICs where smokeless tobacco is a huge issue, and also indoor air pollution that uniquely impacts women. And lung cancer is one of many respiratory conditions that they're at risk for. So that is definitely on the radar of IARC, of the WHO's cancer agency. And there are many people looking at this closely. What can we learn from what's happening elsewhere? Again, that bi-directional, multi-directional knowledge sharing, which is so critical in global cancer control.
And there is also a question about the role of men in our patriarchal systems. What can we really do? What strategies can be incorporated to address their role in these patriarchal systems?
I love this. I think this is probably the last question, given the time. Well, the most important thing we can do is encourage and talk to the men in our lives, our communities, male policymakers. There are so many incredibly supportive male colleagues I have in my own career working in global women's cancer control. And to engage men in families is incredibly important. To get the buy-in from the men, to encourage the women in their lives to have cancer screening is critical. To overcome patriarchy, we need more women in leadership roles. 70% of the healthcare workforce, fewer than a quarter of the women in leadership roles in multilateral and other agencies working in the health sector. We need to change that to move the needle forward on women's leadership.
Thank you. It's been great chatting with you, Ophira. And as I said, I think you've given us very good insights from the other side of very many aspects of implementation and policy and so many things that go into a successful recipe. So
Thanks,
I'll let you go now and hand over to Dr. Vivekanand Jha for his comments.
Thanks so much, Dr. Bhatla, and to the George Institute.
Thank you, Dr. Bhatla and Dr. Ginsburg for that wonderful hour and 15 minutes or so. I can tell you that it wouldn't be an exaggeration to say that it was difficult to tell that so much time has gone by. I'm sure that you will all agree with me that we heard a tour de force from Dr. Ginsburg, and she covered a whole range of issues. There are a number of points that can actually be picked up and repeated, and they're worth repeating, but obviously doing so will take up too much of our time. And the fact that this talk has been recorded and will be available means that we can always come back and pick up those points and share those points with our colleagues as well, because there's a lot of good there. But a few things that really do bear repetition is the need to engage communities directly. For far too long, we have not been doing that. And towards the end, I think the question of a role of men is critical there. We are talking about women's health, and it's fair to say that most of the decisions about women's health has been made by men, which is a big gap. Not only by men, but one group of men arguing with another group of men in deciding what to prioritize regarding women's health. That situation needs to change, and needs to change yesterday. So that's something which we thank you for picking up. Similar point that you made was that those who are dying are not the ones who are making health economic decisions or again, doing prioritization. So how do we make sure that we hear the voice of the vulnerable, the disenfranchised really? I think that's something which is important for us in low resource settings to think of. Often as practitioners of medicine, we become desensitized because we have been practicing in, maybe high-minded hospitals and often are not able to see too far down the road. So that's also an important point for us to remember. And with all of that, the activist message that you threw in, the need for anger, and the need for anger is critical, and not only in the activist community, but really all of us need to have a bit of activist in ourselves, and pick up on what we see is not from the point of view of causing anarchy or disruption, but for making the world better for the next generation, and also for our colleagues around the world who need the support of those who have the means to do so. And also to you, Dr. Bhatla, for bringing out all the points in such nice conversational manner that it just built upon all the messages that Dr. Ginsburg had presented in her talk. So thank you also, and thank you to all of the attendees who stayed on. I'm sure that you will go back and talk about this lecture with your friends and colleagues and share with them the lessons that we have learned. I, for one, have to say that I'm taking a few points myself from this. Although I'm not a women's health researcher, I'm not a gynecological researcher, but I think the general points that you made about health systems are valid, no matter which field you work in, and that needs to be woven into any research agenda that we as health researchers think about. So I have to say that this is really something which the Evidence2Policy lecturer for next year will have to really cross the bar which you have set, Dr. Ginsburg. So thank you for that. What we need to do now is to, if we had a physical event, we would present you with a scroll. And I'm not sure if Meher or Tarun, you are able to show that on the screen at this stage, which we should, it's a small one, but basically we extend our sincere appreciation to you, Dr. Ginsburg, for delivering the lecture on this topic. And we express our gratitude for your excellent address and in recognition of your global work in advancement of women's health and impact you have had in the field of medical oncology, cancer prevention, and gynecological health. Thank you so much for spending your time with us. And thank you, Dr. Bhatla, again for supporting this work and supporting the discussion. And I would also like to thank all of my colleagues at the George Institute, Chavi Bhandari, Kanan Krishnasamy, and Meher and Tarun, and many other colleagues who have worked behind the scenes to make it all possible and allow us to have this wonderful event, which went through flawlessly. Thank you all very much, and we hope to see you again soon in one of our future events.
Thank you.
Thank you so much.